Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
In our last podcast, we discussed hypoglossal nerve stimulation for the treatment of obstructive sleep apnea. Today, Dr. Mike Olson, an otolaryngologist and head and neck surgeon at Mayo Clinic and an expert in surgeries for sleep apnea, returns to discuss other possible surgeries for this common condition. Mike, let's start with pharyngeal and related surgeries. The original UPPP, uvulopalatopharyngoplasty, had a bad reputation, poor efficacy, severe postoperative pain, and in unskilled hands, changes in voice and swallowing. But the approach to pharyngeal and base of tongue surgeries has changed with the current generation of sleep apnea surgeons. Could you tell us how you assess patients for the most appropriate individualized surgery in this region?
Yeah, Mike, that's a really great question. And I think it will be better understood if we look a little bit back at the history that you point out. Prior to even CPAP being an option to treat obstructive sleep apnea, we really only had tracheostomy in regards to the management of sleep apnea from a surgical perspective. And of course, patients don't frequently want to entertain that consideration. And then in about 1981, the UPPP, or soft tissue surgery, as I like to describe it, was developed. And that was a big advance. Imagine for patients who had no other option, instead of having a tracheostomy, go towards something like soft tissue surgery. But what we found out, and what you point out in your previous comment, and that if you employ that surgery on every single patient in front of you, you're not going to have the outcomes that you desire, which is specifically making sure that you meet or get the right patient, the right surgery. And so when we're looking at that, evaluating a patient in the clinic for pharyngeal types of surgeries, the things that we generally look at are things like, how much tissue is there that I can remove? Having a surgery that just takes out very small tonsils and trims a palate is probably not going to be very successful for a patient overall. So we like to see what the tonsil size is. We assess the redundancy of the soft palate. We assess the back of the throat tongue tonsil tissue to make sure that's not enlarged. And then when we put that all together, we can get a little better idea for the patient about what their outcome might be. And even in the sense of, evaluating that patient in the clinic and sometimes using things like drug-induced sleep endoscopy, we sometimes don't have a perfect way to determine who's going to have the greatest amount of success and who isn't. But in general, as we're discussing throat and soft tissue, the individuals that tend to do the best with that surgery are the individuals with excessive throat tissue. So somebody with enlarged tonsils, a long redundant palate, those patients tend to do the best, and that's kind of what we're looking for when we operate on when we offer that patient a surgery like soft tissue.
And how well are these more modern, tailored surgeries tolerated? Does the
Yeah,
patient have to stay in hospital after the procedure? Is pain still a problem? And what about those problems with swallowing and change
great
in
question.
voice?
Yeah, great question. So the older, what we call UPPP, which is uvulopalatal pharyngoplasty, was a surgery that essentially took out more palatal and tonsil tissue than we do today. So there are a number of different varieties of what I would describe as a modern or a modified UPPP surgery, where we're focusing more on tissue preservation, but uh, advancing the soft palatal tissues, and so not removing them, but trying to make them more forward in the mouth so that they don't have the propensity to obstruct in the back of the throat. Now, unfortunately, these surgeries have, you know, more favorable outcomes from a complication perspective than we used to see with the standard UPPP, mainly when patients had more tissue removed from their soft palate. They had higher incidence of the palate not working effectively after surgery. We call that velopharyngeal insufficiency. Essentially, what that means is that the palate is not closing the nose off from the mouth when a patient is swallowing or when they're talking. So with the newer surgeries, and so we're not taking more tissue out, we're repositioning that tissue, we allow it to be more functional. We move the scar tissue from in the old way on the bottom part of the palate and move it onto the front part of the palate. And these alterations have significantly improved the potential risk of complication, like you point out. But unfortunately, no matter what type of surgery you're doing versus the older, the newer types of pharyngeal surgeries, it is an arduous recovery. It is 2 weeks of a quite miserable recovery. And I tell my patients, you must be prepared for this. Now, everybody gets through the recovery. It's not easily forgotten. But in the end, 2 weeks is a fairly short-term time frame to give up for hopefully the outcome, which is improvement of their sleep apnea.
And I'm sure you give them good analgesics to get them through it.
Yeah, yeah, we certainly provide a multimodality pain management to these individuals, and I would love to be able to say to every one of my patients that this will be a breeze and we'll get you through this, but it is a tough go, and but obviously a surgery that's warranted in a number of patients, and important to recognize the utility of it.
Do they go home the same day or do they stay in hospital?
This is very dependent, actually. I take more of a nuanced approach to this. Mostly when I'm admitting a patient for observation is the severity of their sleep apnea. And if they have any other comorbidities or other challenges that makes me worried about them in that first 24 hours after surgery. So for instance, if somebody presents and has a mild case of sleep apnea, has failed all other types of therapies, and we move forward with the soft tissue surgery, I feel comfortable observing them in the postoperative care area for a number of hours. And if they're doing well from a pain control and oxygenation perspective, I'll let them go home the first day of surgery or the day of surgery. But anybody who really has a higher rate or a higher level of sleep apnea, for instance, severe sleep apnea patients, sometimes even moderate sleep apnea patients, individuals with a higher BMI, I tend to be more conservative, and we usually admit for an overnight observation period.
Good. And what about the success rate? I know that it's very individualized, the surgery, but when you're
Yeah.
talking to the patient, how do you quantitate this in a way that patients understand their chances of success?
Yeah, this is a super important question. So, in general, when I quote what I would describe are the big studies looking at the success of soft tissue surgery, I do give those, I do give people the numbers or the percentages that I would define success as. What success is different for many people, but in general, the two things that I look at are, well, what's the sleep apnea? How does that sleep apnea respond? The apnea and the hypopnea index is a common marker that we assess when we are looking at success. So that's one thing. Other things like improved daytime symptoms, patients' reduction in their sleepiness scores is another. For some individuals, snoring is their primary reason for pursuing therapy. So that's another reason or another marker of success. But let's start off with the AHI reduction. When you look at the large meta-analysis at this particular surgery, about 20 to 25% of people have curative results with this surgery, which is relatively low, especially as you compare it to things like PAP therapy, which is obviously very, very high. Now, for individuals with moderate or severe sleep apnea, I generally quote them about a 60% chance of success. And success, in my estimation, is success at making their sleep apnea safe. So taking them from taking them from moderate to severe sleep apnea and making them or putting them into a mild sleep apnea range, which would again then reduce their risk of long-term complication. Now, we also have very specific studies looking at multi-level surgeries in this type of pharyngeal surgery type. Whether you do just a palate surgery or you do a palate surgery and couple it with a lower airway surgery like a hyoid suspension or a partial glossectomy, which is a partial removal of the back of the tongue, or even a lingual tonsillectomy, which is removal of the tongue tonsil. And we know that with multi-levels of surgery, we tend to get better results. Now, specifically, how do I impart that large group of studies on that specific patient? One of the ways that we do this is we have a scoring system that we call the Friedman Tongue and Palate Scoring System, which is an analysis of tonsil size, position of the tongue in the mouth, and the lower levels that we see on this scoring system generally impart a better post-surgical outcome. So for instance, when I'm examining a patient and I see somebody with large tonsils and I can see all of their structures in their mouth when they open their mouth, they have a better likelihood or a more improved likelihood of success versus when I see somebody in the clinic and when they open their mouth, all I see is their tongue and they have very small tonsils. So that scoring system still is a very important scoring system that we use to hopefully provide patients a little bit of forewarning or a little bit of a assessment of what we could get out of this surgery. That's how I generally do it.
Okay, that certainly makes sense. Let's next consider nasal surgery. Now, we generally teach that nasal obstruction plays only a minor role in the genesis of OSA in most patients. Is this correct? Can nasal surgeries, such as correction of nasal septal deviation, alone alleviate sleep apnea?
Yeah, Mike, you're very correct. So in general, when we're looking at a group of, let's say, 100 patients with sleep apnea, and we employ nasal surgery on all of them for a variety of reasons, we don't generally see a significant reduction in their sleep apnea levels with nasal surgery alone. Now, there are some nuances to that. For instance, a patient with very mild levels of sleep apnea or a patient who has upper airway resistance syndrome, which is a diagnosis probably that we could discuss in a whole other talk in itself. But those individuals with relatively low amounts of sleep apnea and significant structural abnormalities in their nose, if we correct that with surgery, I have had some patients with some favorable results in that particular space. But that's not the majority of patients who are undergoing nasal surgery. Generally, nasal surgery in my practice is utilized for individuals who are presenting to my clinic with challenges related to their CPAP that they can attribute to their nose. For instance, individuals who put on their CPAP device and within a short amount of time are very intolerant to it because they become more congested, or there's a side of their nose that breathes poorly, and so utilizing the CPAP becomes a big problem. We do have good success in that space by doing a nasal surgery or some sort of nasal treatment. It's not always surgery, and getting them some improved tolerance and then compliance with their CPAP machine. But overall, if somebody's coming to me and asking, hey, can I get rid of my sleep apnea with nasal surgery alone? That's typically not what we see with nasal surgery.
Good. Okay. So let's then move to the jaw. What about maxillomandibular advancement, the MMA? The success rate, that I understand, is generally seems to be higher than for pharyngeal surgeries. Is this correct? What success rate do you quote patients for this particular procedure?
Yes, when I'm talking to patients about their surgical options to treat sleep apnea, the general reduction in sleep apnea levels, here's how I describe it. I'll say soft tissue surgery or pharyngeal types of
Mhm.
surgeries generally have the least chance of success. The airway stimulation device has the next higher level of success. And then finally, the success rate for MMA surgery is the best. We generally quote, again, the larger studies looking at this, about 85% of patients will have their severe or moderate sleep apnea be reduced to a mild level. And about 40 to 50% of patients will be cured surgically of their sleep apnea after this surgery. It's a very aggressive surgery. However, it usually takes about 6 to 8 hours of operating. Patients will frequently spend 2 to 4 days in the hospital, and there's dietary changes and potential for complication within that surgery. But still, after 30 to 40 years of this surgery being employed in the sleep apnea patients, we don't have anything that has a higher chance of success at making the sleep apnea go away.
Yes, as you say, despite those really very impressive results, patients often don't want to even consider it when
Yeah.
they hear what it involves. So help our listeners understand, what do you actually do? What is so upsetting to patients about the surgery as you describe it?
Yeah, I think it's a little bit on how you deliver what the ultimate process is. If you're in front of a patient, you say the surgeon's going to break your jaws and move them around, and that's going to make your sleep apnea better. I don't think anybody would really love to sign up for that. But in general, that's what we're doing. We're cutting the jaws in a very specific way, in a very safe way, and advancing the jaws. Why is it so successful? Jaw surgery is so successful because every part of the airway gets larger. The upper airway at the palate, the sides of the throat become stiffer and less prone to collapsibility. The tongue moves forward, and the tongue is a very hard structure to move forward. So moving the skeleton that holds the tongue in place is a very effective maneuver at making the sleep apnea better. And interestingly, as I talk to patients about it, they will commonly think, well, this must be a very painful operation. And comparing that operation, for instance, to throat surgery, the individuals who had to have both, every single one I've ever spoken to would say that the jaw surgery was not as painful as the throat surgery. The intensity of the throat surgery is much higher than the intensity of the jaw surgery, where the difference lies with the jaw surgery that there's a longer course of recovery. You know, moving jaw bones around requires 6 weeks of a dietary change. It has facial swelling associated with it. There's some numbness that occurs that hopefully is temporary, but in some patients they have some permanent numbness to their chin and lower lip. And so because of that, those lists of a prolonged recovery and some additional opportunity for complication, a lot of patients, as you point out, are less enthusiastic about this type of surgery. But however, I just don't have anything that's better. Really,
Are the jaws wired after surgery?
no, you know, the good question, and one that frequently comes up in the clinic. No, the jaws are not wired after surgery. Some individuals, some surgeons use sort of rubber bands to kind of keep the jaws in a relatively close position. I haven't found the need for that. And so once the patients exit the operating room, they are unrestricted in regards to their mouth opening. But of course, they have to be counseled that opening does not allow them the ability to just eat whatever they desire because those bones are healing and they need to heal in the proper position to avoid complication.
So it's sort of a liquid diet for 4 to 6 weeks?
Yeah, generally we start off with a fairly liquid diet for the first week, and then I transition them fairly quickly to a softer diet. I tell people, look, we can put solids in your mouth as long as you don't have to rely on chewing those solids to make you be able to swallow them. So things like very overcooked pastas, mashed potatoes, scrambled eggs, all those that you can get in the mouth and not really have to chew much. Those are allowed for that first 6 weeks.
Okay, so it doesn't sound too terrible. You've just got to get psyched into it, and
Exactly.
that's what I'm going through.
I generally, you know, the patients really, who decides to do this? I think, you know, the people who have skeletal facial abnormalities, where a jaw is smaller or larger or asymmetric in its, in how it comes together, are good patients for this. And a patient who really wants to have the greatest chance of post-surgical success. I think that's another patient that commonly thinks, look, if I'm going to go through a surgery to fix my sleep apnea, what's the one that's going to provide me the highest chance of success? Those are the individuals that generally head in that direction.
Well, that was going to be my last question about it. Is the success rate greater if there's obvious retrognathia or abnormalities in the jaw, or is it
Yeah.
about the same for someone who seems to have a completely normal aligned jaw when you see them initially?
No, there are some, for instance, let's take a case where somebody has a particularly small lower jaw,
Mhm.
a hypoplastic lower jaw. In general, when we move the lower jaw forward to meet the upper jaw in that case, we want to move both jaws together. So when you have a particularly small lower jaw, the limitation of how far you can move the upper jaw exists. Now, that doesn't mean that they can't be surgically successful. In fact, for some individuals, the lower jaw is the primary source of their obstructive sleep apnea. So correction of that generally imparts that we're going to have success. But when you look at somebody who has both upper and lower jaws in a normal position and we're moving them forward, those individuals have, in some respects, a greater airway opening because you can move the upper jaw in a good degree and you can move the lower jaw in
Oh,
a great
right.
degree. It's a very nuanced question. In general, when you look at everybody in those big groups, they all typically have a good amount of success associated with it. I've found that individuals with, you know, single jaw abnormalities and with sleep apnea, it's almost always related to the fact that they have those jaw abnormalities. So by correcting that, even if we can't move one jaw more than the other, we still get good sleep surgical outcomes.
Mm. Well, that's very important because intuitively people would think that if you've got an abnormal jaw structure, those are the ones who are going to do the best. And what you're
Yeah.
saying is they may do equally well, perhaps even with a normal jaw, they may even do a bit better, which is sort of counterintuitive. So I'm pleased you clarified that. That's very, very helpful. Thank you for sharing your expertise. Are there any final messages about sleep apnea surgery you'd like to leave with our listeners?
Yeah, this is thanks for the opportunity, Mike. I've enjoyed these conversations quite a bit. What I typically tell patients when they come to the clinic is that my job as a sleep surgeon is education. Of course, we examine the patient. We look carefully to see if we see any significant airway abnormalities. But my goal is to guide a patient through all their decision-making processes to ultimately make the best decision for them. It's more frequent that I'm sitting in with a patient and I say, look, you could go through soft tissue surgery or pharyngeal surgery. You could go through airway stimulation therapy, and you could even go through jaw surgery to fix your sleep apnea or to make your sleep apnea better. But the time that we spend in the clinic, discussing each of the intricacies and the outcomes of each one of these measures is the most important part. So, when patients come in and they say, well, what would you do, doctor? I mean, tell me what surgery you'd want I should do. It's a more of a frequent, example where I say to them, look, they're all available to you. What makes the most sense to you? Is it something that you feel comfortable using a remote control, like with the airway stimulator? Do you want the greatest chance of surgical success? Maybe we should talk about soft tissue or jaw surgery. Do you have a lot of throat tissue in the back of your throat? How should we look at it from the perspective of pharyngeal surgery? So this is the important part of having a comprehensive look at somebody from a sleep surgeon's perspective, is that we can tailor and hopefully educate patients to make the best decision for them.
Thank you so much.
You're welcome. It was great talking to you.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.